Computer. All right, good afternoon, everyone. Thank you so much for joining us for today's webinar, which has been the ongoing series that we've been doing through the ACL project. So I'll introduce myself first. I'm Amanda Perez, and I'm with the Center on Brain Injury Research and Training. And today we have the lovely Caitlin Sinovic, who is joining us to be talking about the screening for brain injury in vulnerable and at-risk populations. Caitlin is an occupational therapist whose professional experience and research has been with populations experiencing homelessness, psychiatric conditions, and health comorbidities, including traumatic brain injury. She is currently a subject matter expert with the National Healthcare for the Homeless Council, specializing in addressing the cognitive and functional needs of those experiencing homelessness, with a goal to develop resources and training for clinicians and providers of vulnerable populations. A couple of housekeeping things before we get going. So as many of you have gone to lots of these Zoom meetings, I'm sure you're going to be familiar with this, but this is a little bit different in that this is a Zoom webinar. So as such, all of you will be automatically muted, but that doesn't mean we don't want you to participate. So we will ask for you to use the Q&A function, which is live at the bottom of your screen, and also to use the chat function. Typically, we like the Q&A to be used for any questions that you might have for Caitlin, and there'll be opportunities throughout where we'll have a screen and a pause that you can just jump in and say what you have on your mind. I would also encourage you that if you do have questions and you don't want to forget them, if you put them there, I will read them as they come up. So we do want you to ask your questions as we go along. Technology being what it is, I would appreciate if you put any questions that you have relating technology in chat, and I will try to help you with those while the webinar is ongoing. Other notes of some import as well, that this is a project that is supported by ACL, and so that is funded in part by a grant, and that's from the U.S. Administration for Community Living, Department of Health and Human Services, and also through the ACL Underserved Populations Work Group. So that is my spiel, and I'm going to turn it over to you.
Great. Well, thank you everybody for joining this afternoon. Today's topic for this webinar is going to be screening for brain injury in vulnerable and at-risk populations. And I should say that I just recently transitioned to working for the National Healthcare for the Homeless Council full-time. So I'm happy to be a part of that organization, but a little bit different than when we initially started these webinars here. So let's go to it. So just previous webinars that this series has introduced, Carolyn Lemsky and John Corrigan both gave webinars talking about traumatic brain injury, mental health, addiction, behavioral challenges, substance use, and those were all really good sort of stepping stones to this particular webinar, because as you're going to find out, the issues that are discussed in today's webinar, and these issues are all cross-cutting and layered, especially in working with people with brain injury, and is very relevant to vulnerable and at-risk populations. So if you haven't had a chance to view them yet, I definitely recommend that. So our objectives for today's webinar, we really want you to be able to identify certain vulnerable and at-risk populations in the United States, those especially affected by brain injury. And hopefully by the end of this, you will also be able to demonstrate an understanding of why we might do brain injury screening in these populations, and possibly even feeling comfortable in implementing and interpreting the Ohio State University Traumatic Brain Injury Identification Screening Tool, also known as the OSU TBI ID. So, and the importance of screening for brain injury. So before we go into the actual screening, just to build a little bit of understanding on what a vulnerable and at-risk population is. So depending on the service organization, there are different definitions as to what a vulnerable population might be. The general idea is the same, but there are definitely some variations between HRSA, the World Health Organization, and the Centers for Disease Control. But really, the summation, the overall idea is that vulnerable populations are those at greater risk for poor health status and poor healthcare access. And this is recognizing that these are not necessarily personal factors of the individual who may be at vulnerable, but often due to economic and sociological circumstances. And then we also see the term at-risk populations. At-risk populations is a little bit more of a fluid definition in that somebody may be at risk in a certain circumstance, but maybe not at risk in others. And again, there's some variations in the definition of what that means depending on the organization. The National Response Framework includes a very long list of folks, including people with disabilities who are in institutionalized settings, et cetera. Health and Human Services includes those populations, but adds in those with chronic medical disorders and pharmacological dependency. And the Association of State and Territorial Health Officials adds even further to that, those at economic disadvantage and a lack of a support system. But really at risk is sort of termed in response to a certain event. So you may be an at-risk population in one circumstance, but not in others. So it's a little bit more related to the context and that need. But again, regardless of these definitions, the idea is that it's often folks who have limited ability to communicate. So that could be communication difficulties, but also access to technology for communication. Need support for functional independence, may have transportation needs, are economically disadvantaged or socially or culturally isolated, perhaps maybe a refugee population in a certain area. So again, that's a little bit fluid, and what we're going to talk about these today, vulnerable and at risk, really in the context of who is vulnerable for experiencing a traumatic brain injury and also at risk for negative complications after experiencing a brain injury. So there's a few different populations that we're going to talk about today. One of these is adults experiencing homelessness, those who are victims of domestic violence and interpersonal violence, adults who are incarcerated or engaged with the criminal justice system, adults living in poverty, and underserved rural and frontier communities. And actually, there's one bullet point on here I didn't write in, but also veterans who were dishonorably discharged. And we'll go into a little bit about what makes that population different than veterans in general. So when we're looking at traumatic brain injury in adults experiencing homelessness, there's a lot of data out there to identify that many adults who are currently homeless have sustained a TBI at some point in their lifetime, upwards 50% of the population, if not more. And there's a high correlation of mental health symptoms and a history of TBI for this population. And more than 25% of adults experiencing homelessness have sustained a moderate to severe TBI, which we'll go into what constitutes that later, but it's related to loss of consciousness. The data that I find really, really interesting and really something telling in terms of our healthcare system is that when doing all of this research and interviews, they actually found that 50 to 90% of those who had experienced a TBI actually had the TBI before their first experience of homelessness or marginal housing. So I think there was this prior belief that homelessness may have caused a TBI because of the decreased safety and increased risk of assault, but actually there are many individuals where the first TBI happened even before they were homeless. We can maybe project why that might be the case in terms of aftercare and functional difficulties, but there's not sort of this clear linear relationship as of yet that has been established. And then even mild TBI survivors and those who survived a moderate or severe TBI report having semi-permanent or permanent deficits that impact their performance in daily routine activities, which to me supports why those who had a TBI before they were homeless may have become homeless. Those who have been victims of domestic and interpersonal violence, similarly to the homeless population, it's underidentified in survivors of domestic and interpersonal violence, likely due to the fact that when these injuries occur, the victims are not going to seek medical care as they're going to be living in those unsafe circumstances. A woman's face, neck, and head are most frequently injured during a physical domestic violence incident, and emerging studies indicate that victims have below average recoveries from TBI, which again is not surprising if you consider that these injuries are occurring while the person is living in this unsafe and violent situation. It's going to result in the person not seeking medical care, the chronic stress and trauma of living in that situation or having recently left that situation is also going to impair recovery. There was one study, there was a large study done in Ohio, and they found that 85% of survivors of domestic and interpersonal violence had experienced a blow to the head, which is a significantly high number. And 50% of those women said that they had been injured in the head more times than they could count. Similarly, they found that they had also experienced strangulation, which, although is not necessarily considered a traumatic brain injury, can result in an anoxic brain injury with similar long-term effects. And 88% of those women also experienced that multiple times. So there's a lot of data to show that this population is incredibly at risk for head injury, but it's very much underidentified. Individuals who are or have been incarcerated also are at greater risk of having a TBI, similar to the population of individuals who are experiencing homelessness, that often the TBI predates the first interaction with the criminal justice system. So there's definitely some postulations that a TBI may contribute to having a higher risk of engaging in with the criminal justice system or of reoffending, likely due to impacts on the frontal lobe that increase impulsive or aggressive behavior. They also find that children who have experienced a TBI are more likely to have a criminal offense or a criminal record later into adulthood, and juvenile offenders are also more likely to have a TBI than the general youth population. So this population, as you can imagine, also has a pretty limited pretty substantial underidentification of TBI, and we can assume that that lack of identification is going to contribute to ongoing problems. Individuals living in poverty overall have poorer access to healthcare. And so if they've sustained a TBI, they may be less likely to be placed in rehabilitation settings because they don't have insurance or don't have the funds to cover that care. And they may simply just not seek care after injury, again, from not being able to pay the medical bills associated with that. There are some studies that indicate poverty may increase risk of sustaining a TBI. Again, these are correlational, so there's not a direct cause, but there is some crossover in that those who are victims of domestic violence are more likely to be living in poverty. So some of these populations kind of overlap with each other. And those living in poverty, their caregivers may not be able to give long-term care and support. And so these individuals, again, may have limited recovery and have less access to adaptive equipment and devices that might aid in recovery. And also considering, again, thinking about those factors that have led someone with a TBI to become homeless, that if you're already living in poverty, but maybe making minimum wage, if you're injured and you lose your ability to return to your employment, you're likely then going to slip into poverty, worsening poverty or homelessness. And then rural and frontier communities also have an increased risk for underidentified TBI, likely not seeking care for mild to moderate TBI, again, due to limited access to potential healthcare services, especially specialized care. There's also an increased risk just from the daily life roles and activities that come with living in these communities. If you're a farmer or a rancher, engaging in large equipment, you definitely have a higher risk than perhaps somebody working in an office job. And then for those who have had a brain injury, there's, long-term impacts. There's less support and resources in these communities. Caregivers may not be able to give as much support. Again, that limited access to specialty care. There may not be an outpatient rehabilitation center, within 2 hours of where you are living. And then providers who are accessible, perhaps there's a primary care clinic in that community. They're not necessarily trained to address brain injury and can be really limiting in that long-term care. And because of that, individuals in these communities experience limited reintegration. There's not these, maybe a group home or a day program for people to participate in, and they become more isolated. And there's also been identified that this population has underdiagnosed long-term psychiatric needs, again, lacking access to that specialty care that can really overall impact recovery from a TBI. And then veterans living in the community. So they're, since in maybe the last 10 to 15 years, there's been an increased recognition of the prevalence of brain injury within the veteran community and those who are currently serving in the military. But there's sort of a special sub-pocket of veterans in that there's a group of veterans who have been dishonorably discharged, which means that they were discharged and because of the circumstances around that, don't have access to veteran and other VA services and supports. But there's findings that indicate that these dishonorable discharges often are related to behaviors that may be a result of a TBI and or co-occurring post-traumatic stress disorder. And so a study on this issue found that over 10,000 former military service members may have been discharged due to having actually a TBI and subsequently didn't receive any transition supports, mental health, or ongoing medical services that they might have needed. So this population, because they don't have access to veterans benefits and VA care, will be receiving care in community settings. But this group is actually less likely to seek needed medical care and often feel ostracized because, you know, they were discharged for behaviors that maybe were not fully within their control. And those who've had a dishonorable discharge are related to several negative consequences. Again, looking familiar at these other at-risk populations, such as homelessness, criminal justice involvement, and higher presence of substance use or mental health conditions. So these at-risk populations, individuals can fall in one of them. They might fall in all of them, certainly cross-cutting. And that's why it's really, really important to screen for brain injury because somebody may have had many of these factors increasing their risk. So if you have an undiagnosed or untreated TBI, it can exacerbate any health and social inequities, right? So if you're a person experiencing domestic violence and you have a brain injury, it's going to increase the difficulty in leaving that abusive situation, not just because of the psychosocial issues with doing that, but because it may really just be incredibly difficult to identify, execute, and implement a plan to safely leave or to access services in order to leave. Those who've had a TBI are going to have difficulty remembering shelter or program roles, whether it's a substance use program, a homeless shelter, you know, a criminal justice rehabilitation center, any of that. It's going to be really hard for people to follow those instructions. And those involved with the criminal justice system will have special difficulty because the systems, once a person is not incarcerated, all of the different steps they have to do to navigate that reintegration, different dates that they have to meet with their parole officer, different classes that they have to do, criteria they have to meet, is going to be incredibly difficult with a TBI. And also even following rules and commands while they're incarcerated. That might lead to harsher punishment or delayed being released from incarceration. And for all of these groups, it's going to make it difficult to navigate complex resource systems. I think we all hopefully have had the opportunity to apply for healthcare insurance, but understand how complex and confusing that process can be, even for those of us who haven't had a TBI. And so adding that on layers and layers, you know, social service programs, supplementary income programs, really, really difficult to do. And then the complications of TBI can really increase that. So because of that, we really recommend brain injury screening. You know, in addition to all of these reasons, a history of brain injury might not be known to somebody's current provider. So somebody might have sought care in another state, and we don't have access to those medical records in order to know that it's there. If we suspect a brain injury, we can't always see it. So if somebody has an MRI or a CAT scan, it's not necessarily going to show up unless there was significant physiological damage to a part of the brain. And someone who didn't seek treatment for a TBI because they didn't have insurance, because it happened while they were living in a domestic violence situation, would have no medical documentation regardless. And so screening is going to be the only way to document that, in addition to old records not being available. And really, we want to screen because the effects of TBI can impact the treatment and services that somebody is receiving. If we're providing care and services to someone, we want it to be the best care, client-centered, person-centered, and the best way to do that is to understand where the person might be coming from in that situation. So now we're going to go a little bit more specifically into the brain injury screenings themselves. So there's a lot of indicators for screening. Some of them sort of we've talked about when reviewing these populations, but these are some reasons that you can kind of keep for yourself. If you hear this, if you're not doing a routinized screening program where everyone gets screened, these can be some red flags to say, hey, maybe we should screen this person. That can be anyone who hints at or discusses any sort of head injury or concussion when they're talking about their medical or their life history. Anyone who's currently experiencing physical abuse, trauma, or domestic violence, or has experienced that. Any history or recent physical assault from any set of circumstances, somebody who reports falling at home, frequent dizziness, or who you observe to be really unsteady when walking. Anyone really over the age of 62 is at increased risk for falls, which then is at increased risk for head injury. Again, someone who has a history of seizures or uncontrolled seizures, similarly to somebody who's frequently dizzy, there may be these small minor head injuries from falls that are happening, but accumulating over time may be problematic. Anyone with a substance use history, again, increased risk for falls and anoxic injury. And then as we've identified a history of incarceration, there's a lot of relationship between that and is worth screening. And then you can sort of observe some of these behavioral factors as well. Somebody who seems to have difficulty remembering information, who has a hard time paying attention, who seems to be disorganized or can't locate things. I know I've seen that, but I can't find it. And their backpack, their bag, their pocketbook is just, incredibly disorganized, can maybe a sign that there's something more going on there cognitively. And then also someone who appears to have mental health symptoms, but there's not a clear history of it. There's so much overlap between mental health diagnoses and a history of brain injury that for someone who sort of has these chronic ongoing difficulties or even this unexplained episode of psychiatric issues, that screening for brain injury might be appropriate, as that brain injury may have caused some of these issues or may be related to it. So there are a lot of different options for screening for brain injury. Today, I'm going to focus on the Ohio State University TBI identification method, which I'll refer to as the OSU TBI ID for the remainder of this webinar. There's a few reasons to pick this one, and all of these are well-rated and valid screening tools, so it's worth looking into them a little bit more. Of all of these, the OSU TBI ID is actually the shortest and requires the least amount of training in order to implement, so any type level of provider could do it. Obviously, a neuropsych evaluation has to be done by a neuropsychiatrist, which can be harder to access in certain communities. So the BISC and the HELPs, I believe, take maybe 30 to 60 minutes to administer, whereas the OSU is about maybe 5 to 15 minutes depending. So there's definitely a difference in that. There's certainly doing questionnaires or medical history, but sometimes this is not comprehensive enough to pick up on a history of brain injury. So I'm going to go through the OSU TBI a little bit more in detail. So it's a short structured interview, and it was actually, I should say, developed by John Corrigan, who gave the first webinar in this series. And he's done a lot of work on this and these populations. And the benefit of the OSU is that it identifies TBIs that may have been undiagnosed, untreated, unknown to providers. And the wording of it is pretty sort of colloquial terminology, right? So it's not asking someone, have you ever had a traumatic brain injury? Because if you don't think you've had one, the answer will be no. Instead, it asks more about life events in language that is going to be more receptive for individuals. It's been tested with a variety of populations, actually those with substance use history, those who've been incarcerated. So I've used it a lot with individuals experiencing homelessness. So it's one that has been identified to be suitable for these more at-risk populations when often tools are not tested on those. And it is also a valid and reliable measure in terms of psychometric properties. And also there's a lot of great online resources there. There's the website listed at the bottom of this slide. It's also at the end as well, but they have, I guess I should mention another really big benefit of this tool is that it's free, and all of these resources are free, and so you can download the forms online. There's an extended, about an hour-long video training on using the tool online. There's related resources and publications, the papers. If you're interested in the research piece of it, that's all available here that you can look into. So this is the form itself, and I believe this handout was also sent along at the beginning of the before the training. But again, it's available for free. So this is what the form looks like. And we're actually going to walk through this form and how to administer the tool. And then this is the back of the tool. So before we go through that walkthrough piece of it, I wanted to give a couple case examples of how this tool can be used and how this can help different individuals. And all the names have been changed, but the stories are real. And so it's really important, I think, to see how relevant this is in day-to-day settings. I will give a note, there isn't an example of our rural community, primarily because I've worked in urban areas for most of my clinical experience. So, but Derek was a 32-year-old male who came to our clinic seeking care, medical care, and mental health care. He had been arrested sort of in this mass arrest of everyone that was living in his building due to suspicion of drugs. After that, he was held in jail for 3 months, but then released because there was no evidence that he was involved in anything that they were looking for. When he was released, he didn't have any supports, any services. His main support system was his mom, who lived in a senior housing apartment, but wasn't allowed to have guests for more than 14 nights in a month. So because of that, Derek would go there to help her, spend the days there as he could, spend nights, but spent the rest of the night sleeping on the street since he didn't want to risk her housing status. But he came to staff at our clinic saying, you know, I can't tolerate the shelter setting. I'd rather sleep on the street. He also identified difficulty with remembering information and really having a hard time doing things in the community. He would say, my mom would send me to the store for 5 things and I get there and I don't remember what they are. And then I come home with the wrong stuff, or I go back and forth and I'm really frustrated. He also had a hard time tolerating noise, crowded areas, and frequent angry outbursts, which he wasn't really sure why those were happening, and without any substance use. So we administered the OSU with him, and which identified that while he was incarcerated, he actually had a fall from a pretty high level bunk bed, which resulted in a significant head injury with intracranial bleeding. So they treated it medically, basically to stop the bleeding. And then after that, he received no other care and services. And so he was having a lot of these ongoing complications due to that injury, but hadn't put those pieces together himself. So this is an example of what his OSU screening tool looked like. The questions that he answered yes to, what the cause was when it happened, and how, what the level of the injury was. So then we have George, who engaged with the program after 20 years of homelessness. He reported that there's sort of this like downward spiral in which he became divorced, was incarcerated from a DUI. After that incarceration, he was fired from his job and lost all financial resources and essentially spent the next 20 years living in a tent under a bridge. He came to the clinic eventually to get treatment for frostbite in the winter, and was receptive to receiving services for what had been identified as ongoing depression and anxiety. He was actually accepted into a supportive housing program through the city, but was required to go through all of these sort of steps in order to identify housing and use his voucher and sort of check mark all of these steps in order to get his apartment. And he had a very hard time with that in remembering information, organizing his paperwork. Anytime he hit a barrier, he basically threatened to quit, thinking that going back to his tent would be easier than trying to navigate this process, and had a hard time making his own decisions because he was so overwhelmed by what could happen by them. When we did the screening, we identified that when George got his divorce, he actually had been in a serious car accident where he was in a coma for a week. And following that, it developed a pretty significant alcohol use problem, which then resulted in his DUI and incarceration. And so again, that traumatic brain injury was sort of this pivotal point in which several negative things happened to him, and he had a hard time recovering from that, partially because of, sort of the lack of support systems, but also his inability to resume his previous roles due to the impact of the head injury. And his screening tool looked like this. So again, identifying the injuries that he might have had when they occurred and how the level, I guess how the injury was, the severity of the injury. Thank you. So another story was Al, who was a 61-year-old man who came to a local health center after breaking his hip. He had also been living in a tent in the community for a couple of years and came after sort of an immediate medical issue. He had a degree, had worked as a library assistant, lived abroad teaching English, and had been very social and engaged with others. When he came to the clinic, he had a diagnosis of major depression and general anxiety disorder, and a history of alcohol use. He had a lot of difficulties with balance that were sort of unidentifiable as to why these were happening, but resulting in frequent falls and contributing to a lot of his anxiety. His story is interesting because when the screening was completed, he denied any history of head injury. But when the questions came up about asking about being in a coma or loss of consciousness, although he hadn't had a head injury, he did identify an experience where he had a seizure and was face down in 2 feet of water for several minutes before he was found, resulting in a coma for about a week, and really doesn't remember many events following that. And this was not anywhere in his medical records, and his providers weren't aware. And although he wasn't sure if this impacted his physical or mental health problems, the likelihood, given his functional status, was likely that due to this injury. So again, this is what his brain injury screening looked like. And then we also have Jenny, who is a woman living in the shelter. She had been living independently, but really no community supports. She had a lot of hospitalizations from exacerbation of her diabetes, recently with a lot of wounds and toe amputations. So she transitioned to a recuperative care floor after the most recent hospitalization. A lot of difficulty managing her diabetes, missing medical appointments, not able to remember appointments, really frustrating to providers who thought she just wasn't motivated or taking it seriously. She also noted that when she did come to the clinic, that if she had to wait, she became overwhelmed, often because she was late or on the wrong day, had long wait times, and would leave before being seen. She had trouble managing her medications, changing medication doses, which we know can happen frequently with diabetes, and had a hard time remembering her recommendations. So the TBI screened that she had actually a pretty significant history of abuse, both physical abuse by her mom and multiple assaults from a previous boyfriend that resulted in loss of consciousness, when pretty severe stabbing, where she was unconscious for several days as a teen. So again, this is what her screening tool looked like. And for time's sake, I'm going to skip this one, but it is in the handouts as well. So those were all real case examples and should maybe give you a little bit of a picture why these screening tools can be so important. None of those individuals came to the clinic for care for traumatic brain injury, but upon screening, we figured out how much that traumatic brain injury and that history had played into what their immediate and current health effects were, and really allowed us to tailor our interventions and plans to better meet their needs. So on the screening form, it looks a little overwhelming at first, but it really is not difficult to administer. So first, you're going to follow step 1, and you're going to ask questions 1 through 5. And those answers get recorded over on the side. Show the arrow again. Step 1 there, you record the cause. So you go through each questions 1 through 5, checking yes or no in the column, and if the person answers yes, then you record that cause in the chart. The second step is that if the person answers yes to any of those questions, then you go through the next set of questions and record the answers down below. So those questions may be, were you knocked out? Did you lose consciousness? If so, for how long? And did you have a dazed or gap in memory? And how old were you when the injury occurred? And you'll go through and fill that out for each of the times the person answers yes. Next, if there's any time, you'll ask the question, has the person been a time where they experienced multiple injuries to the head? So this will capture those individuals who maybe sustained abuse, also those who have a strong history of sports injuries, anyone who boxed for a period of time, played football, this will come up here. And just like the others, you're going to write down the cause of the injury, go through did you lose consciousness? What was the typical effect? So most often what happened from that, and then the most severe, which may be different. So the person may, most of the time, oh, I felt a little dazed or dizzy, but there was that one time where I was knocked out for a good couple of minutes. And you'll record both of those, as well as the age that the repeated injury started and ended below. So now I'm going to show a quick clip of it actually administering the OSU TBI. Hi, good morning. So I'm going to be asking you some questions about any injuries that you might have had to your head or neck in your lifetime. We're hoping to be able to find out if any of these things have happened to you, because sometimes that can help us figure out maybe what's going on when you talk about not having good memory or having difficulty focusing. Helps us get a bigger picture of what might be going on.
Okay.
Does that sound okay? All right. So I'm going to run through some questions with you, and then once we're done with those questions, I'm going to ask you for a few more details.
Okay.
Okay. In your lifetime, have you ever been hospitalized or treated in an emergency room following an injury to your head or neck? Think about any childhood injuries you remember or were told about.
No.
Okay. In your lifetime, have you ever injured your head or neck in a car accident or from crashing some other moving vehicle, like a bicycle, motorcycle, or ATV?
Yes.
Okay. And what was the cause of that?
I wrecked my bike.
Okay. And there was just one injury from a moving vehicle?
Yes.
Okay. In your lifetime, have you ever injured your head or neck in a fall or from being hit by something? For example, falling from a bike or a horse, rollerblading, falling on ice, being hit by a rock?
Yes.
Okay. What was the cause of that?
Bike accident.
Is that different than the one you just mentioned, or the same accident?
Same accident.
Okay. Have you ever injured your head or neck playing sports or on the playground?
Yes.
Okay. And what was the cause of that?
Was hit in the head with a baseball.
Okay. In your lifetime, have you ever injured your head or neck in a fight from being hit by someone or from being shaken violently?
No.
Have you ever been shot in the head?
No.
Okay. In your lifetime, have you ever been nearby when an explosion or a blast occurred?
No.
If you served in the military, think about any combat or training related incidents.
No.
Okay. All right, so now I'm going to ask you for a few more details about the bike accident and the baseball that you mentioned before. So when you wrecked your bike, how old were you?
I would say 11.
Okay. And when that happened, did you get knocked out or lose consciousness?
Yes.
Okay. Do you know about for how long you lost consciousness?
Very briefly, maybe 10 seconds at most.
Okay, so it was maybe less than a minute.
Mm-hmm.
Okay. Afterwards, did you feel dazed or did you have a gap in your memory?
Yes.
Okay. Okay. And then when you were hit by a baseball, did you get knocked out or did you lose consciousness?
Yes.
Yes. Do you know for how long?
Very short again.
Okay, so less than a minute probably. Okay. And did you feel dazed or dizzy afterwards?
Yes.
Any gaps in memory?
No.
Okay. And how old were you when that happened?
12, 13.
Okay. Okay. Are there any other times where you injured your head that I haven't asked about that we haven't talked about today?
Several times.
Several times? You want to tell me a little more about those?
Just hit my head around household things around the house, whether it's shelving or cabinetry, things like that.
Okay, gotcha. Any of those times did you get knocked out or lose consciousness?
At least twice.
Okay. For about how long?
Very short again, under a minute.
Under a minute? Okay. And you'd say that happened twice?
Mm-hmm.
Did it happen close together or were they separate times?
Several years apart.
Okay. And how old were you, if you can remember, when either of those happened?
I'd say late 20s, early 30s.
For both of them?
Mm-hmm.
Okay. But not any time close together?
No.
Okay. Any other injuries that you can remember?
No.
Okay. Any other times where you lost consciousness for a long period of time, maybe more than a couple of minutes?
No.
No. Okay. All right. Do you have any questions for me?
No, ma'am.
All right. Thank you so much. I appreciate your time.
Thank you.
Okay. Okay, so I would like to pause here and answer questions that you might have so far on administering the TBI or screening, why we want to screen for brain injury in general.
So for those of you who have questions like that ready for Caitlin, please put them into chat. I'm realizing that the Q&A that I referenced at the beginning doesn't seem to be available on the screen for today's session. So go ahead and use the chat box, which should be in the bottom middle of your screen. And then while we're waiting on that, there were a couple of questions earlier, Caitlin, about veterans. Would you like to talk about those?
Sure, yeah, we can do those.
Okay. So in the first question, this person asked if you could also discuss veterans who are other than honorably discharged. There says there's 3 types of discharges, and they're not sure what the other than honorable discharge means regarding continued health care coverage.
Generally, from my understanding, that other than honorable discharge, those folks similar to dishonorable discharge do not have access to the full veteran services, such as VA healthcare or otherwise. I think the bigger difference is that other than honorable discharge, it's easier to dispute your discharge status than if you have been dishonorably discharged.
Thank you. And this one, wants to know what is the percentage of dishonorably discharged veterans compared to those who've been honorably discharged or who were currently serving in the military?
That's a good question. And I don't actually know the exact data on that. If that is asking like the general number of individuals who've been dishonorably discharged versus honorably, I'm not totally sure. I do know that those numbers, about the 10,000 that had been dishonorably discharged since about 2012, this was an issue that came to light, especially after people had served in the Afghan or Iraq wars, because of the high incidence of traumatic brain injury that was due to being exposed to explosives or IEDs, which is why that sort of critical issue came up. But I don't know the total like comparable percentages.
Okay. Thank you. And then some questions have come back in, I think, related to what you were just talking about. So Lizzie Martin wants to know, do you ask step 2 questions immediately after someone answers yes to a step 1 question?
So in the typical administration, you would ask all of the step 1 questions and then move to step 2. I, in clinical practice, have found that sometimes it is more natural to go through the step 2 questions as soon as somebody identifies yes. It's not standardized that way, but sometimes based on how the person is responding, maybe they start telling you about it after they answer yes, that using those more motivational interviewing techniques, it's more natural to complete step 2 as soon as someone says yes. So the standardized approach is no, you complete all of step 1 questions and then step 2, but sometimes it's just better to go through the step 2 piece of it. I also find that I prefer to do that when it's someone talking about a trauma history or an assault history. I don't want to hear about it and then not ask a question and then kind of poke back at it again. So you might decide that it's just clinically more appropriate to do that way.
Thank you. Looks like this question's for me. Audrey, yes, we will be recording this, and we are actually recording it now, and it will be available for reference later. Lori has a question. Says, any suggestions on how to handle emotional moments that might be triggered when administering the screener?
Sure, yeah, absolutely. And I didn't do it in this one because due to COVID, this was someone that I had a very good understanding of what their brain injury history was. But yes, if it's someone that I don't know, sometimes I will warn them that, especially that if it's talking about trauma, one, that they don't have to answer the question if they don't want to talk about it or go into it. They don't have to. Obviously, I'm missing that information, but you have to decide what's most appropriate for you to gain from that circumstance. They may respond yes, and then you don't have to ask details of it, knowing that perhaps in the therapeutic relationship you'll be able to revisit it later. And I do warn people, kind of giving that caveat. I'm going to ask about injuries to your head or neck. This can be really helpful for us in determining what to do, because I think people are afraid maybe that it could be stigmatizing in some way, or that we're finding something wrong with them. So I always try to frame it in that, like, this is to help us understand how your brain works better. And if that's the case, we can help work with you better and know it's going to be helpful. But you do have to be prepared for that. There have been a couple of times where I was caught off guard by the person unexpectedly telling me about a pretty significant trauma history. And that wasn't really well recorded anywhere. And so, I had to sort of check in with myself during that too, because I was not prepared for that. But it did demonstrate to me the importance of why we do it.
Thank you. I think following along that same line, Guyleen wondered if it's important to make a note of possible trauma triggers in that process.
Yeah, absolutely, right. You can use this sort of in tandem with other screening tools or interviews that you might be doing with the person, because this might open up, some stories about information that's going to be helpful, and you can use it in that way. It's a standardized tool, but it's not so standardized that, like, you have 15 minutes to administer it and you have to ask all these questions in one session. Again, use it as you feel like is clinically appropriate.
Okay. And then Katie wants to know whether or not this tool needs to be administered by a mental health professional or healthcare professional, or is it appropriate for non-clinical settings or other community-based programs where higher risk individuals may be present?
It's absolutely appropriate for community settings. I would recommend anyone who does it, who is going to administer the screening, go through the training modules online, either watching this webinar or the ones that are produced by Brainline and John Corrigan, so that you know to administer it. And it should just be someone who can do it in a trauma-informed way. Just as we mentioned, this might bring up some issues and triggers. So maybe not necessarily like a front desk staff who's not been trained in that way, but a first-line case manager or someone absolutely could administer it.
Okay. And I want to be sensitive to time. There are other questions coming in. Do you want to cover those now or hold on?
Let's move through the scoring piece of it and see if any of those questions perhaps get answered with scoring and interpretation.
Okay.
And then if not, we can hold them all, and I'm happy to stay on however long is needed at the end to answer folks' questions.
All right, sounds good.
Okay. So you've administered the TBI, the OSU TBI ID, you have this history. So now the next question that often comes up is, what do we do with this information? So scoring the TBI, this was my practice. Your agency or program can determine what is the best practice to record this data for you. I like to administer paper tools. I think it's easier to write and collect information. So whenever somebody finished that, once I finished screening the tool after the session with the person, this interpreting findings section is where I would do my first scoring. So in that, you basically, as you saw in my examples, is you circled all of the ones that apply. If it was a worst injury, a first injury, multiple, recent, or other. And the criteria or definitions for that are on the tool underneath each of them. And the reason why these are specifically the criteria is that these are the things that are most likely to cause ongoing problems for a person. If they've encountered a moderate or severe TBI, which is the worst injury, a TBI with loss of consciousness before the age of 15, multiple TBIs, so a time in which they experienced two TBIs close together. So you saw in the interview for the individual who had hit their head at home, I was trying to elicit, did this happen like both within 1 week or separated by a couple of years, because there's definitely a different additive effect if you've experienced multiple blows within a short period of time. And so again, thinking about anyone who's in a domestic violence situation, how frequently that might be happening to them, that additive effect can be significant. A recent injury for someone who has a TBI within the last few weeks or in the last couple of months, like our individual who had been incarcerated, and then other sources. So a TBI combined with any way that their brain function has been impaired. With my population of adults experiencing homelessness, I almost always circled other. I don't think I ever didn't, because those are people experiencing chronic stress, chronic trauma, lack of sleep, malnutrition, all of these things that can be impacting that. I would also circle it if someone has a substance use disorder or a history of substance use disorder, a history of falls, a neurological condition, right? Anything that when you think about like, hey, this combined with a TBI, like this is going to be something that we need to look at and consider. To identify the worst injury rating, so this is on a scoring of 1 through 5, it's based on the loss of consciousness for the individual. So it could be 1 is a no history of TBI, 2 is that there was a mild TBI but no loss of consciousness, just more of that dazed memory lapse. A mild TBI with a loss of consciousness less than 30 minutes. A 4 is a moderate TBI, so the loss of consciousness ranges between 30 minutes and 24 hours. And then a 5 is a severe TBI, so a loss of consciousness greater than 24 hours. Sometimes people can't remember how long they lost consciousness, which is understandable, especially if there wasn't treatment. I try to have them sort of give the best guesstimate that I can, like kind of asking questions around the circumstances. So, for example, you know, how long were you knocked out for? Like, did you wake up in the hospital? Or, you know, do you remember the ambulance being there? If they remember going into an ambulance, then that's likely less than 30 minutes. If they woke up in the hospital, it's most likely more than 30 minutes, right? Oh, a few minutes, like I was knocked out, and then I woke up and people were looking at me asking me if I was okay. We would assume that's less than 30 minutes. So you can kind of get some contextual ideas to get an idea of it. So this is just another example of someone who sort of has a lot of these criteria that we've talked about here. So someone who had a history of falls, who had a bike accident. So he had 2 moderate TBIs. He was also hit by a truck different times in his life. He was hit over the head with a beer bottle, and he had frequently occurring falls, which you can see at the bottom. One, he, you know, most often he didn't really have any loss of consciousness, but and he reported that he'd never had anything more than just feeling dazed or a memory gap with any of these falls. And so looking on the back here, he had 1 moderate or severe TBI with the truck accident and the bike accident. He had a first injury before the age of 15. It's not circled on here, but he actually had multiple injuries when you consider the frequent falls, and then also other. So the falls, he had a history of substance use, and he was currently using and potentially abusing alcohol. So this gives you an example of what this looks like sort of in the informal form. Before we go to sort of the interpreting and the reporting, are there any questions on the scoring? And again, there's a couple of handouts associated with this that go through sort of a quick reference guide for scoring and also a little bit more in detail on the scoring criteria.
So I'm seeing a couple of people have been asking about handouts. I know some of you received them on Monday. The others, I will make sure I'll be sending out all of those handouts, including these, later on this week. They probably will go out tomorrow afternoon, would be my guess. I don't see other questions related to the scoring, though. If you have them, make sure that you're putting them into chat, and I'll be happy to read those off. It doesn't look like we have questions related to that right now.
Okay, great. All right. So, and if you think of them later, there will be another time for questions at the end here. All right, so now just talking about interpreting. So what do we do with this, right? We've administered it, we've scored it, we know what the person's history is. What we want to consider long-term. So one is that, you know, there's these effects from these different types of injuries that might have occurred. So someone who's had a worst injury is going to have a lot of cognitive effects from that, difficulty with new learning, abstract concepts, planning ahead, thinking, executing a plan, poor concentration. People who've had a worst injury also may have a higher likelihood of experiencing depression and anxiety. So again, that mental health crossover, it's really important to consider. First injury, there's actually a really great study, a long-term study done in New Zealand of children, and they found that early in life injuries can really have long-term consequences. So a child who's had an injury is going to be impacted with their ability to perform in school, and we know that school performance can impact a lot of long-term life situations for folks in terms of employment, higher education, and issues with emotional regulation, which again, maybe are those that then end up with engaging in the criminal justice system early. Multiple injuries can have, if you've had multiple injuries close together, you can have a similar to effect to those who've had a more severe injury. And it can increase the time it takes to heal. And then a recent injury is that the person may still be experiencing more immediate effects, right? Headaches, dizziness, poor concentration, memory lapses, emotional control that may resolve over time, but they may be presenting with that now because of a more recent injury. Again, in long-term impacts of cognition, and the person might not be aware of the problems if it's really, really recent. And then other sources. This is one list. It is not most likely not inclusive of all the other impacts, things that can be impairing the brain depending on the other circumstances that someone are having. So one thing that's noted on the OSU is that it doesn't ask about anoxic injuries, right? So someone who's had an overdose, really that injury, if you had an overdose and were revived by naloxone, the amount of time you spent unconscious could be comparable to the amount of time spent drowning in the bottom of a pool. So it's a pretty significant effect, but it's not one that's necessarily brought up on the screening tool, but definitely would affect cognition and impact. So it's really important to consider that, and sometimes why that question of like loss of consciousness will bring out those stories from people about things that have happened. But relating that to any history of traumatic head injury, we can really identify that there's going to be a lot of problems, that both two things together are going to be worse than alone impacting the brain. So if you're in a clinical setting and you want to document your results here, you definitely should record the results of the screening in the person's medical or organizational history, kind of what their file is. I would definitely, at minimum, recommend documenting the type of injury, so that worst, first, multiple, other, and the worst injury level, so that 1 through 5 scale. And then that actually can be helpful data if you're putting it in an electronic medical record system, like being able to pull that out to look at what the statistics are for your particular program. And it can really be, it's a pretty flexible tool. It can be integrated into any of your processes that are already established for implementing and recording screening tools. If you're a provider that can diagnose, consider adding the results into the diagnostic list. There's the ICD-10 code, personal history of traumatic brain injury. There are a few others that would, depending on your clinical skill set, may also be appropriate, including cognitive impairment, if that's been identified, and different types of cognitive impairment with that, or any neuropsychological effects. And really the importance of adding this to a person's medical problem list or history is that it makes the person more eligible for potential resources. If there's a traumatic brain injury program in your community, a specific rehabilitation program, if you're trying to access SSI benefits, or there's a housing program for people with brain injury, this is going to make them eligible for that if they have this diagnosis. Without it, it's not going to be in there. And it also can help you figure out, okay, maybe we need to try to dig up some medical records somewhere for the person. And then engaging with the person, right, which is really why we're all here, is to be better at engaging with the people that we're serving. And identifying a TBI sort of answers that question like, oh, they're not motivated. Oh, this is just behavior, right? I think that often happens with people who are more difficult to engage. And really a TBI might be the cause of that. It's not that they're more difficult, it's that they're engaging differently, or they have different needs than who we might normally be seeing. It also then helps you address potential and likely cognitive impacts, perhaps a referral to a rehabilitation program for occupational or speech therapy or neuropsych evaluation. And also helping you as an agency identify the need to use environmental and external strategies with this person. So instead of verbally giving them information, can we give them handouts? Reteaching information in a way that's understandable. And our next 2 webinars are really going to go through what those are a lot in detail. And then helping you adjust treatment plans and supports to adapt for the cognitive impact. What are really realistic goals and expectations for this person who's not only recovering maybe from trauma or experiencing homelessness, but also recovering from a TBI? That's a lot to deal with in all of these factors together. And then presenting to your interprofessional team, if you're the person who's done the screening, including that history for them, identifying to the team, what are the problems, behaviors that we might seeing? If you're engaging with non-clinical staff who are less familiar with TBI, helping explain and educate, like, what's this showing up as and why, so that we can respond in a way that's better. Again, identifying cognitive issues and what sort of follow-up needs to happen with that, developing an accommodations plan, maybe a rule, okay, well, normally we give people 15 minutes and then they're a no-show, but this person, let's give them 30 to help them try to engage with their team. And just advocating for additional services and care to address what they have going on. All right, so now, with 1 minute to go, I'm happy to answer any remaining questions that folks might have.
Thank you, Caitlin. That was really fantastic. So one of the ones from like I think 2 sessions ago from Russ Bierman, he wanted to know if you're aware of any successful efforts to screen people with no health insurance in rural communities, including people who are homeless, and how they went about getting an actual diagnosis and follow-up support other than an FQHC.
That is a really good question. So I know that there have been different communities. There's a community in Wisconsin actually that has, specifically in their shelters, implemented brain injury screening tools. So there's a few initiatives where people at homeless shelters, not at a medical or an FQHC, did the screening tool. And so it doesn't necessarily have to be a medical facility that's implementing the screening. I know there was a couple other questions embedded in that. Sorry.
Yeah, it's okay. It was a long one. It looks like we have some comments from people too responding to that. So there's vocational rehabilitation services may be able to assist with getting a screening, was a comment from Melissa Kronberger. And I kind of feel like maybe this is going to be further answered as we get into your other talks and your other screening, not screening, your other webinars that you've got planned too. Russ, if you're still on, if you have follow-up questions to that, please feel free to type those in, and I'm happy to read those as well, since there were several layers to that particular question.
Yeah. But yes, there are screening initiatives that have occurred in settings that are not related to an FQHC or a health center. And it's totally appropriate and can be implemented by non-clinical staff. The limitation with that is that there's not a diagnosis, right? A formal diagnosis that can be made unless you're a provider who, if that's part of your licensure. Mm-hmm. But that doesn't mean that that information is not helpful, right? Knowing a history of a TBI for someone is absolutely really clinically helpful and relevant. The diagnosis may just perhaps make people more eligible for certain programs that might exist in the community.
Yeah. And I feel like Lori's question here kind of speaks to that as well. And she says, can you explain the difference between screening versus diagnosing TBI? The versus
Sure.
Screen versus diagnose.
Yeah, so a screening tool, like any screening tool, right, is identifying an existence of an issue. So if you do a TBI screening tool, you're saying identifying basically a history, like sort of a medical history. From that, then you may further delve into questions or a more extensive diagnosis for someone. And so if you identify that there's a pretty substantial TBI history and a lot of ongoing problems, you may then refer the person to a neurologist or a neuropsych for further comprehensive evaluation, and they may add diagnoses into that. So it's not, it's sort of like a way to gain an idea of what a problem might be and what services a person might access if you're not a diagnostic provider. Another example is the PHQ-9, which screens for depression, right? So that questionnaire looks at, are there signs and symptoms that this person has depression, but it doesn't necessarily, it's not enough to say substantially like this person does have depression unless you're someone who can look for that, if that makes sense.
Mm-hmm. Yeah, it does. And then Russ just said he was interested, he was just interested in next steps for someone with no health insurance, and if anyone has been successful in connecting people to supports.
Yeah, that's really tricky. People who are in non-ACA expansion states definitely encounter more barriers to accessing services for these populations than those who are in expansion states. not a fancy way around that. Sometimes, again, that screening is helpful if you have someone that can add the diagnosis to support being eligible for certain services. So like if you have someone with like an anxiety disorder and a TBI history, that helps their Social Security income case. And if you are eligible for Social Security, then in some states you're more eligible for Medicaid or Medicare, even if you're not an expansion state. So there's, some ways around that. Trying to think, because rural communities, I think, is specifically what you're asking about for, right? There's not an immediately accessible federally qualified health center, which would serve somebody without insurance.
Right.
But it may be worth, it may be an effort of advocacy if it's something you can identify in your community. I'm sorry, I don't have like a shorter answer for you on how to navigate that. But if other folks have had that experience and want to type that into the chat, any resources or thoughts, that'd be really helpful.
Yeah, and I would say, Russ, I'll be sending out emails later if you do have follow-up questions on that or a specific community that you are wondering about. You're more than welcome to email that back, and we will see if we're able to look up resources in your area as well.
Yeah.
So then Guyleen has been thinking about common diagnoses in school-aged children. We've got ADD, ADHD, ODD, etc., and wondering if it's possible those can be misdiagnoses for TBI. And
yes,
what your thoughts are.
Absolutely. Yeah, there's a lot of initiatives, some national, some state level, depending on where folks are, to actually do TBI screenings in schools because of that particular issue. Children who have unidentified TBIs, more likely from sports injuries, but also could be experiencing violence at home or just sort of these random events, again, poverty, not able to access healthcare, not going to the doctor. That they're not getting the accommodations they need to be successful in school. So there actually is some advocacy efforts to integrate that into school health histories and programs, and for kids to more easily get services that they need from that. There's also an overlay with children who are experiencing trauma, sort of that same misdiagnosis of ADD, ADHD, ODD, when really it's a trauma issue going on, in addition to TBI. Yeah, fetal alcohol system. Yeah, so there's sort of this, it could be both in a lot of cases, but usually TBI and PTSD or ongoing trauma are under-identified.
Yeah. Okay, well, this was a pretty robust chat and set of questions. Thank you, Caitlin, so much for going through all of those. For those of us who are still online, which looks like there's quite a few of you, I just wanted to remind you that the next webinar in this series is going to be on January 13th, 2021. Same time, 12 to 1 o'clock Pacific Standard Time, which I know threw a few people off with a little bit of difference in time zones. So do be mindful of that, and it will be on accommodating brain injury in vulnerable and at-risk populations. So.
Great. And posted our resources, but these are also in any of the handouts that will come with that, some different places to get some more information.
Okay. Well, Caitlin, thank you so much. I'm going to go ahead and stop recording.